It has been a really excellent session since morning, and I thank the Chief of the Army Camp, Dr. Charuhas, who has made us sit on and keep us alert by making us stand and then sit down. Well, he has a meaning to all this, because vestibular system is something which has not been dealt at all probably in the medical college days, and it takes time to understand all the intricacies of this vestibular anatomy, the physiology and all these things. Well, he has a purpose behind all these things, and by tomorrow evening we will definitely have pearls of wisdom to be taken from him and the other faculty members. I come from a small place in Maharashtra called Dhule. It is north of Shirdi and Nasik. I started my neuro-otological career 10 years ago. I took my initial training from Dr. Anirban Biswas, and I have been interacting and going along with so many of my faculty members to various workshops and conferences, and I am still a student of neuro-otology. I have been given a topic, that is Tumarkin's Otolothic crisis, and Dr. Charuhas mentioned right now how important it is to understand for all of us, because as we become audiovestibular physicians or specialists in the near future, we would be dealing with patients who come to us with sudden episodes of drop attacks when they come for some analysis and then treatment about. Let me begin my presentation. Well, this was a famous clip which most of us have seen. It is from the movie Vertigo by Alfred Hitchcock. So we begin the presentation on this drop attacks. Well, the drop attacks which specifically as a vestibular specialist we need to know about is about the Tumarkin's otolithic crisis. These drop attacks are also described vividly as sudden falls without any warning. When it happens because of a vestibular origin, they are because of the erroneous signals which happen from the saccule. Let us see how a typical drop attack looks like. It occurs instantaneously, it's without any warning, it is without any loss of consciousness, it lasts for a minute or less, it is not associated with any autonomic symptoms like nausea, pallor, sweating, and it's generally without sensation of spinning. The patient can immediately get up and resume his activity. Only if the individual suffers serious bodily injury, the outcome will differ. Rarely it can be morbid or fatal due to head injuries. Before 1936, if you go through the pages of literature, not much has been mentioned about drop attacks being attributed to the vestibular system or the origin being from the vestibular system. Earlier it was felt it was probably because of brainstem ischemia or vertebro-basilar insufficiency, and these were the remarks made in the previous literature. But this gentleman, Alex Tumarkin, being a British otologist in 1936, proposed otolithic vestibular end organ malfunction as a cause of drop attack in patients of end stage Meniere's disease. He called these drop attacks the otolithic catastrophe. The diagnostic criteria which needs to be applied to label a patient of being of Tumarkin's otolothic crisis, we naturally have to understand the historical part, the examination part and the investigation part. In the history, we definitely will come to all the presenting features a person will have that will give us an idea whether the person has got a Meniere's disease. We all are aware of the triad of Meniere's, that is tinnitus, hearing loss and vertigo. So, naturally you will have a patient who will be giving you a history of the repeated episodes of vertigo which he has been facing over the last few years. Maybe the literature also mentions a person to have a drop attack because of Meniere's, he will be having Meniere's for at least a few years, maybe around 5 years or so. So, it will be a end stage endolymphatic hydrops. The sudden drop attack without warning while standing still, not induced by motion, would be the history. There will be no aura. There won't be any post-ictal signs which you see in a patient of epilepsy. It will not be associated with any loss of consciousness, except associated with an head injury if a person gets when he has a drop attack. There won't be any perioral numbness, there won't be any tingling, double or blurred vision, there won't be any occipital headache, which all these symptoms will to give us an idea there is a neurological involvement. What do we expect in physical findings when we see a patient who complains of a drop attack? Essentially, we will have to go through a thorough neurological examination, and the neurological examination we will have to conduct all the tests for the cranial nerves, we will have to see for the motor system, we will have to see for the sensory system, and essentially it would be normal. We will be definitely having some hearing loss when we test the patient. It can be unilateral or bilateral. We will be able to see a unidirectional gaze nystagmus in these patients. We come to specific neurotological examination. We have already described and seen since morning how we go through the vestibulo-ocular and vestibulo-spinal system. We have seen about how to test the smooth pursuit, the saccades, and these can be seen in our clinical setup through the video Frenzel's or Frenzel's glasses. We can go through the head impulse test with the help of the VHIT machine. For the neurotological examination, we need to test for the vestibulospinal system. And we have seen just in the previous lecture how to test the vestibulospinal system. We have these various tests at our disposal to see how it works. We have the Romberg's, the Fukuda's and the Unterberger's tests, which all will suggest about the unilateral vestibulopathy. Further, we investigate these patients. The important investigation we'll have to do is the audiometry, which will clearly give us an idea whether the person has got a unilateral or bilateral hearing loss. Further, we go to electronystagmography or the video nystagmography, where the caloric test will either be normal or show a reduced response. It can be unilateral, it can be bilateral, depending on the stage the person who's having the Meniere's comes to us. It is essential, some residual function is usually demonstrated in the affected ear. We have two more faculties which can give us an idea. WEMs certainly help us in diagnosing these patients of drop attacks, because we will definitely have a low amplitude WEMP in a patient of Meniere's, more so in such patients who have got a drop attacks. Certainly there will be a low amplitude WEMP seen. The subjective visual vertical may not be of much use as it takes care of the utricular pathologies. Since morning we have seen an excellent anatomical and physiological facts. It is just to give you a revision of what has been said in the morning. We have two types of motion sensors. The semicircular canals will deal with the angular acceleration, and the utricle and sac will take care of the linear acceleration. We have seen these neuronal connections between the vestibulo-ocular and the vestibular-spinal tracts. What actually goes wrong in a patient of mean years so that he develops these drop attacks? We need to have some considerations in mind before we think of what a drop attack would look like. The pupillae and maculae are pressure sensitive. Well, we have seen that in the morning in an excellent presentation by Dr. Srinivas. In normal condition, the vestibular system gives inputs about the gravity vertical. Any abnormality in the vestibular fluid and changes in electrolytes can lead to endolymphatic hydrops. This is the fact we know about Meniere's disease. And constant and sudden changes in endolymphatic fluid pressure can cause inappropriate stimuli to either sensors in cupula or macula or both. Taking into consideration all these facts, this is actually proposed by Tumarkin what actually happens during a drop attack. There is sudden endolymphatic pressure change. This will lead to vestibular stimulation. This will lead to disequilibrium. Inappropriate automatic reflex muscle movement will happen, and it removes the body support platform which is provided by the feet. Gravity pulls the individual to the floor before visual and proprioceptive impulses recognize, assess and correct, and this is proposed explanation of Tumarkin's otolothic crisis induced falls. Well, if an individual of endolymphatic hydrops has to develop a otolothic crisis, some vestibular function must be preserved. If it's a completely dead organ, there is less chance or no chance of a TOC happening in this person. What we have been using over the years is a caloric test to assess the activity in the labyrinth, and this caloric test will always give you an indication whether there is a hypoactivity or hyperactivity. Over the years, there have been presentations and literature is supporting some patients of Tumarkin's otolothic crisis who have undergone vestibular deafferentation. This confirms the peripheral vestibular cause of these attacks. This is what we mentioned in the beginning. In the earlier stages, brainstem ischemia due to Meniere's was considered as a cause of drop attacks. Well, once we have diagnosed the patient with drop attack which is secondary to Meniere's or it is a Tumarkin's otolothic crisis, we have options how to treat these patients. The first option would naturally be medical treatment. Vestibular suppressants have been asked to be given by the people who have been dealing with these cases, and it has to be given on a prolonged duration. This is one of the indications when you will have to give vestibular suppressants for a prolonged time. Literature also mentions about injection fentanyl, which we have been using during the anesthesia, and this has been given once or twice a week in patients to be treated for Tumarkin's otolothic crisis. Intratympanic steroids, as we give in patients of Meniere's, intratympanic gentamicin also has been recommended. And if none of these medical therapies work, we have the option of surgery, and probably we'll have some more insight into what type of surgical treatment can be offered in tomorrow's lecture. The surgical treatment can be either vestibular nerve section or labyrinthectomy. This can be decided looking at the facts. If the hearing is conserved, naturally we'll have to go for the vestibular nerve section, but the hearing is hampered and it's almost a dead ear, then we can think of labyrinthectomy. So that was a glimpse into an attack of a Tumarkin's otolothic crisis. It definitely becomes imperative on our part to understand whether this person of drop attack is because of Tumarkin's otolothic crisis. And we'll have to go through various causes of drop attacks, commonest being the cardiac arrhythmias, the hypotension, vertebrobasilar insufficiency. Some types of epilepsy may present with drop attacks, multiple sclerosis, drug-induced motor disturbances, and to add to these causes, we have so many other causes with spinal deformities, deformities in the joints of the lower extremities, and many other causes which can lead to drop attacks. Symptoms of blurring vision, diplopia, perioral numbness, transient loss of memory, aura, warning, loss of consciousness, all are features of drop attacks due to neurological causes. Just a small video to give us an idea how an epileptic drop attack may look like.
Attacks me, I just feel an aura. That's, I feel some bitterness in my throat. And when I just feel like that, I just go sit down on a safe place where there are no things that can hurt me. I just forget everything. I just lose consciousness completely. But after some while, that's around 3, 4, 5 minutes, I just get back to normal. When I start getting back to normal, I just feel dizzy, very tired. Slowly, I just come to normal, but with no clear vision, with no clear sight, that is. But slowly I just sit down. After a while, for around, after around 10, 20 minutes, just come to normal completely.
So there is a definite difference between the two attacks. One is with an aura, one is without an aura, and you can clearly make out how immediately a person rises after Tumarkin's otolothic crisis. So I conclude by saying Tumarkin's otolothic crisis is caused by inappropriate stimulation of the otolothic receptors in saccule in patients suffering from endolymphatic hydrops. Thank you for the patient listening. Thank you very much.